Well, good morning, everyone, and welcome to today's UKPIPS community event. Meg Fuller and I, the trustees of UKPIPS, are absolutely delighted to see you all here today. And we do apologise for having to cancel last year's event, which was due to low numbers. We have more attending today. We hope more will join us as the event goes on. And we do trust that we have a very interesting and informative event for you. First, a small admin point. This event will be recorded, so we can send it out to the members who have not been able to join us. So if you have any objections to that, you have this opportunity now to blank your video. I'll give a few seconds for people to do that. Okay, assuming no objections to that, let's move on to the agenda for the day. After this welcome introduction by myself, I'm delighted that Professor Alex Richter is able to join us as the highlight speaker of the day, our keynote speaker. I'll say a bit more about Alex a little bit later on. Following the talk by Alex, there will then be a question and answer session where you can put questions directly to the professor. And that Q&A session and another one that comes later will be hosted by Emma Coldray, one of our volunteers. Following that Q&A session, there will be an NHS update by Sue Dimmitt, one of our more active volunteers and very active involved with the NHS, which seems to be a moving feast all the time. So it'd be interesting to hear how they stand at the moment. And then there'll be a short session on changes to personal independent payments in Scotland, and that will be by Meg Fuller and Michael Howe. Following that, I'm sure you'll be grateful to have a short comfort break. Then when we come back, Errol, one of our volunteers, will talk about the survey which trustees did towards the middle of last year, and also how we're progressing on fundraising, which is a key priority of the trust. We'll then have quite an important question and comment session for all. And I have to say, the aim of today is really to have a two-way flow of information. We want to provide you with some informative information and an update on UKPIPS. We also want your feedback to know what services we need to prioritise going forward. And in this Q&A session, you will have the opportunity to ask questions of the trustees. And we want to know particularly what you want out of UKPIPS. We have limited resources. We as trustees need to know how to allocate the resources to give you the best service that we possibly can from UKPIPS. This is your opportunity. Now, to ask questions, you can either ask them directly during the Q&A session. The host will unmute you and you can ask the question direct. Or if you prefer, you can do this at any time, you can put a question into the chat box, which is at the bottom of the screen. Okay, you've heard enough from me. Let me introduce to our keynote speaker. And as I said earlier, we are very grateful that Professor Alex Richter is a very busy person. He's able to speak to us today. Some of you may know, Alex is an academic clinical immunologist. She runs a clinic at University Hospitals Birmingham, looking after patients with both primary and secondary immunodeficiency. And during COVID, she's run a number of national studies, including the COVAD study, which was specifically looking at COVID immunity in antibody deficiency patients. She's been involved in a number of national committees, and today she intends to tell us a little bit about her work and how she sees the future for immunodeficient patients during this time of living with COVID. Professor Alex Richter, Over to you.
Thank you very much, Paul, and thank you so much to everyone for inviting me. If it's all right with you, I will just share my screen now. Okay, so you've been living with immune deficiency, many people, for a number of years, and we know that there is an ongoing risk of infection, don't we? And that's what we're tackling all the time. And so along comes a brand new infection, COVID-19, and it was really important for us to understand what that meant for patients with primary immune deficiency. Now, if you remember all the way back in February, March 2020, it was really, really a great unknown. And many people coming into hospital had this hyperinflammatory syndrome, so that the immune system was kind of being overreactive. And there was real uncertainty as to whether patients with primary immune deficiency might actually do quite well because they weren't getting this inflammatory syndrome, or which was probably more likely because they are prone to infections and more severe infections, that they would be particularly vulnerable during this pandemic. So working with the UK Primary Immune Deficiency Network, I set up a survey of all the centres around the UK to have a live update on our knowledge of patients that were getting infected, getting hospitalised, and what was happening. And we reported this back in 2020. So this is following the first wave. It was my colleague Adrian Shields in Birmingham that pulled it all together. And we found that really there was quite an increased risk from infection in patients with primary and secondary antibody deficient immunodeficiency. And, you know, much higher rates of hospitalization. If people were hospitalized, unfortunately, the outcome wasn't so good compared to the general population. But that was then. And an awful lot of stuff has happened since then. We've got vaccines, we've got treatments, we've got, you know, knowledge about the virus and how it's transmitted. So what I'm interested in today is not really thinking about the past, but what's going on now and where do we see the situation now. But to do that, we need to understand a little bit about what has happened and what the impact of treatments and vaccinations, etc., are for patients with immune deficiency. So just highlighting the original data we had on the right-hand side is if people got COVID, immune deficiency patients got COVID, unfortunately, we were finding the mortality rate about 20% or even 30% in patients with secondary immune deficiency. So very, very high risk. Now, some of this is distorted because we weren't testing regularly. So people with mild disease didn't know they had mild disease at this point. And so we've got a very at-risk symptomatic group that were attending hospital usually. And as you can see, that risk of dying was pretty high. Now, this reduces tenfold, over 10 times in the Omicron wave. And there's so many things that have improved there. One is we're testing more. One is we've got antiviral treatments, and the other is we've got vaccination. So I guess, you know, one of my key overall messages from today is things are so much better. Now, things are better, but they're still not as good as they are for the general population. And I guess some of that is not surprising. We know patients with immune deficiency have always had an increased risk of infection. And not only that, they have an increased risk of severe infection. So that the risk remains as it is for all infections, but it is much, much better is a key message. And this is data from the big national ISRIC study, which looked at patients hospitalized with COVID. And if you take the top dot on this graph, that's the first wave when the Wuhan strain came in from China. And if we look at the subsequent waves in immune competent people or healthy people, that outcome has massively improved. But when we looked at patients that had an underlying health condition that meant that they were immune vulnerable, their starting point was at a much higher risk than those that were healthy. And although things have improved, you can see from this graph as the dots move to the left, that actually things have improved, but not as much as those who are healthy. And we looked a little bit at this data through this national study that I did with Siobhan Burns in London and Adrian Shields in Birmingham, called COVAD, which a number of you would have been contributing to. So thank you for that. And what we did is we looked at the rates of infection in our COVAD population, and we compared that to the general population. And what we found is during lockdowns, between the general population and the COVAD community, infection rates were fairly similar. And as soon as the country started to open up or, had periods not in lockdown, those in the general population got much more infections than our patients with COVAD. And as we've really opened up, and whatever Freedom Day was to Boris Johnson, rates in the population massively increased. And whilst rates in the COVAD community and our immune deficiency patients have increased, they haven't increased to the same extent. So if we take just a cut point in February 2022, 70% of the whole population had COVID at least once. And this was only 22% in our COVAD study. So what this tells me is that as a community, you're very good at shielding and preventing yourselves from getting infections. And a lot of this is what you've learned to do through the years to try and keep well from all infections. But also that potentially you've been taking advice from government and advice on social distancing and mask wearing more seriously than those that don't have an immune defect. So what this does mean to me, tell me, is that the burden of COVID in the immune deficiency population is probably underestimated, because I know that there's still a number of people that are, if not completely shielding, being pretty careful about how they go about their day-to-day business. And again, this is directly from the COVAD study. And the first graph is showing, compared to the different population, that if we look at hospital patients, the percentage of patients in hospital with an immune deficiency were much, much lower than those with the general population. And that's because you guys just hunkered down. You absolutely knew that this was going to come with force. And I think, it was very clear that you avoided infections. But if you look at the graph below, you can see that the blue bars, which are the immune deficiency bars, now far outweigh the red bars. And what that is telling me is that hospitalizations now disproportionately affect the immune vulnerable and immune deficiency patients. So the pandemic has changed for you, it's changed for the NHS, and actually for national policy, what I'm very much arguing is that, the exit strategy, which has worked for the general population, we now need an exit strategy for patients who are immune vulnerable, because the pandemic isn't over for the immune vulnerable. And it's how we provide some equity and, re-entry to, to society for many individuals who still feel pretty vulnerable in this situation. And I think the other thing to point out is that at the moment, COVID is not the only severe infection. And there's been quite a lot of discussion in the press about this idea of the immunity gap, and that, we've had not a lot of infection circulating, and now there's much more circulation of infections, and they're taking hold. And certainly for a number of weeks over this winter, which has been very difficult for the NHS, as I'm sure you realise, that actually flu hospitalizations were higher than COVID hospitalizations. That's now reversed again, and COVID remains higher at the highest infection in hospitals. But it's highlighting to me that COVID's not the only problem for the immune vulnerable. And we really have to communicate this to decision makers, that all infections are a problem for the immune vulnerable. And we really need a strategy, because every year we have this chaos of winter pressures and the NHS struggles to cope. And it's really not a surprise, because we do have more viruses circulating in the winter. And guess what? Those viruses mostly affect the immune vulnerable populations. And so we need a plan, not just for the short term for the immune vulnerable, but for the long term. So going back to COVID, what's improved these outcomes? Well, without a doubt, vaccines have played a role. But how have immune deficiency patients responded to vaccination? And if you have responded, is some response better than no response? And also, we've got acute treatments which have been given early, and we've got outpatient treatments now with antivirals and monoclonals, or antibody therapies. And then we've got better treatments when patients come into hospital, and we've got better ideas of how to try and help with the virus when you're in hospital. There has been a theory that Omicron is a milder virus, but I dispute this really. If we look at the cases in Hong Kong and the recent experiences in China, where Omicron has really been quite overwhelming in a poorly vaccinated population. So going back to the COVAD study and looking at how patients have done, we actually had a really, really pleasant surprise when the vaccinations were rolled out. And we found after that initial dose of 2 vaccines that 61% of our whole population had responded in some way to vaccination. And the patients included in this study would have been patients either on immunoglobulin treatment or patients who had failed vaccine responses, but were doing pretty well on prophylactic antibiotics, so weren't eligible for immunoglobulin yet, but had a significant antibody deficiency. So given that these patients would all have responded to the pneumonia not have responded to the pneumonia vaccine and often other vaccines, to have 61% having either antibodies or T cells, or usually both, to these vaccines was really, really promising. And actually, when the government decided to give a 3rd primary dose, if you can remember back to autumn 2021, we found that 3rd dose meant that 76% of you had made some kind of antibody response to vaccination. Now, what we found is that although most patients have responded, often the amount of antibody was less than a healthy control population. And the other thing that we found is often the vaccines that the antibodies produced didn't work so well. So you might have heard about neutralizing antibodies in the press, and this is a study in the laboratory. This is tests in the laboratory looking at how antibodies work. And they find that, they don't work quite so well in all patients with antibody deficiency. But what we did find is that the T cell responses were pretty robust in a lot of people. But we've now got two groups of antibody deficiency patients. So we've got patients that have responded really well or have made some response, so 76%. But we've got a 24% population that have made no antibody response and no T cell response. So for us, these are probably the most vulnerable. And from an understanding the risk for you as patients, this is really important, because there's a really good chance that if you don't respond, if we can understand who the individuals are who haven't responded to vaccination, either through further research, testing, or genetic testing, we may be able to prioritize you for future infections going forward as being the most vulnerable. And that is one of the legacy projects we're going to be doing from COVAD, is trying to understand who is most at risk. Because I think some of the problem we've had with COVID and the messaging around COVID is the government put out this message that all these groups are immune vulnerable. And what we realize now is it's much more nuanced than that, isn't it? And some people have a higher risk than others. And there is tremendous harm associated with shielding, not seeing family, not seeing friends. There's an economic burden because some people haven't gone back to work. And actually what we want to be able to do is personalize and nuance the advice for all of you to communicate your risk and to allow you the power to say, well, I know what my risk is, but I choose to do this, or I choose to do this because this is a high risk activity, or this is a low risk activity. And I think this will be true not just for COVID, but for all infections going forward. Now, as we looked through, sorry about the noise in the background, that'll settle in a second. What we found overall through COVAD, and some information towards that, is if you make an antibody response, it helps. Now, we didn't get what we call a significant difference, but patients that made no antibody response were more likely to be hospitalized, and there were a few more deaths in those that didn't make an antibody response. But it's not a significant finding, just an observation, because we didn't have a large enough study to really say this. And this again will be the subject of future work through a study I'll tell you about called Stravinsky. But the other thing that we found that was significant was that if you didn't produce antibodies, it took you much longer to clear the virus of infection. Now, even in antibody deficiency, the average time to clear the virus was about 50 days overall. Was about 20 days overall. So that's still higher than people with a normal immune system. But if you don't have antibodies, the average time to clear the virus is 50 days. So that's, nearly 2 months to where you've got a chronic infection. And as we all know that, you feel unwell for a really prolonged period of time. The other thing is we've got some patients that really we struggle to clear the virus with. And at the moment, we don't have any policies in hospitals or, studies how we should be clearing the virus in patients that fail to respond to clear the virus. And, my longest case that we're dealing with at the moment is I've had someone that's positive for 1.5 years, and we're trying combinations of antivirals and monoclonal antibody treatments, antibody therapy treatments to try and clear this virus. that all of these require special permissions through the hospital. And this is some of what we're asking the government for is, we really need a decision across the country so that we can all be trying to work the same way to ensure we clear the virus in some patients. So thinking back a little bit to patients that don't make such good antibody responses in COVID, and this is a study from Europe that was presented recently. And what they found was that patients with complications from COVID, such as autoimmunity or other malignancy or granulomatous disease, such as liver disease or additional lung disease, these patients were likely to either more likely to not respond or make a lower response. And if individuals have more than one of these complications, again, there was a stepwise reduction in the ability to respond. So that just helps guide me as a clinician a little bit to say, well, I think, you are more at risk, or actually, what's equally important to me is to be able to reassure some individuals that their risk now is much, much closer to the general population. The other thing to point out is that antibody responses do wane, and these do wane probably faster in patients with a number of immune deficiencies. This is why the spring booster is being announced. And I think I'm expecting immune deficiency patients will all be offered this vaccine. And given the responses that people have made to the early vaccines, I would strongly encourage everyone to go for a booster this spring. And we've got good evidence that there's no waning of that response to the vaccine, and that you just get that top up, which looks valuable. So if you have antibody deficiency, it's a bit different to the general population, because, the government strategy for living with COVID has all been about vaccination, hasn't it? Everything else, we must just crack on. Now, this is more difficult if you've got, reduced vaccine effectiveness. You're still more likely to have a severe or life-threatening infection, or you're more likely to have a prolonged illness that can take months to clear potentially. And how do you live with that uncertainty? And one of the things that has been talked about and has been very active in the press is this concept of passive immunity. So if you can't get really good antibodies from vaccination, can you have antibodies donated? Now, many patients with primary immunodeficiency know all about this because we give you immunoglobulin, and that is a type of passive immunity. I always say to my patients, every bottle of immunoglobulin has about 1,000 people's antibodies in them. And we've got good evidence now, which I'll show you, that there's really good levels of antibodies in immunoglobulin products now. Now, what we don't know is overall how protective these antibodies are, but certainly in laboratory work, it looks pretty good. The alternative for people who aren't on antibody replacement is this monoclonal antibody treatment, and the one that's been in the press a lot is Eversheld. And again, similar to normal human immunoglobulin, you give a dose of these antibodies. And whereas patients on immunoglobulin who have it intravenously either have to have it every 3 or 4 weeks, or if you're having it subcutaneously once a week or twice a week, you only have to have this once every 6 months or even once a year, because the antibody's been modified to hold on to it, so the body doesn't clear it quite so quickly. So these monoclonal antibodies, a bit like immunoglobulin, can be given by injection, and they work very, very rapidly. So they work almost immediately, hours after the first dose. Whereas vaccines, you may not respond, and you may not respond quite so well. And if you do respond, that vaccine response may wane more rapidly than someone with healthy. And also it takes several weeks for an optimal response to occur. Now, both, I think, are therapeutic options, but at the moment, we do not have access to these monoclonal antibodies in the NHS. And I just want to tell you a little bit about what I know about that. So the Evershed study, the original study was called PROVENT, and that was done in a pre-Omicron era. And actually, it made the case for what we call pre-exposure prophylaxis. So giving treatment before you get an infection to prevent you getting an infection and severe disease like immunoglobulin. So it was really successful. There were no deaths. There was a massive reduction in hospitalization. But as you know, with the pandemic, things have evolved very, very rapidly. And we had the Omicron outbreak, and there was some evidence that probably there was some reduction against some of the strains of Omicron of efficacy. And then more recently, there has been a complete change in the kind of the variant of concern environment. And so Evershed was taken with, well, the government made a decision that they wanted NICE to approve or to look and review Evershed and the evidence for this. And one of the things that they did is they looked through all the waves. So if you remember, there was the Alpha wave and the Delta waves and the Omicron wave. And we've been on this massive Omicron wave since last year. But what we're now dealing with is the sons and daughters of that original Omicron. And what NICE did is looked at whether Evershed should be rolled out now. And what they found is that, what the evidence that they looked at was, if you look at how Evershed is performing in laboratory tests, actually it's unlikely any action or only minimal action against 85% of the variants circulating at this time. And these variants are called BQ or XBB if you want to go and look them up. So the feeling was, is because these are the dominant ones, Evershed's unlikely to have any significant impact for the immune vulnerable population this winter. And so that was kind of, I guess, the key element of the committee's decision to not recommending this for COVID-19. Now, I was an expert on this, and so was party to the communications. And I think a number of you probably attended as part of the public as well. And I think we managed to get across, and I think it was recognized, certainly from some of the follow-up emails that I've got, that they do recognize that absolutely there is an unmet need for the immune vulnerable population. So they've made a decision for now, but they realize they need a much faster process for dealing with the evolving pandemic, because, in 2 or 3 months' time, these variants might have evolved. And there is a possibility that actually then some of the variants circulating will be susceptible to Evershed, and Evershed will be useful. And we've got some evidence for that, because one of the drugs that we've been using in hospital and are using in hospital, which the WHO, the World Health Organization, and the American organizations had said to stop using because it doesn't work, there's now reasonable evidence that it might be having some effect again. And so I think we're going to be in this situation where we're going to be variant chasing, and sometimes some monoclonals will be useful for the variant, the kind of what's circulating at the moment. and sometimes not so useful. And so NICE are going to have to really find a way of keeping up to date. And they need to understand they've never had a situation like this before. They need to understand what evidence they should be looking at to approve this, because there is some disconnect between what happens in the laboratory and what happens in real life. And so they need to really understand how they should be approving these medicines going forward. Now, the decision that we had through just at the beginning of February was that they've decided to not license this, but they are going to send the decision-making out for public consultation, and then these comments will be considered by the committee in April. So look out for that consultation. So if antibodies aren't available through Evershed, what about in your immunoglobulin products? Now, David Lowe, who's one of the immunology doctors down in London, has led a project looking at putting together all antibody data from the current products. Now, this is a little bit out of date now. So actually, this is October. So the position is even better. And actually, all products have some antibodies in them. And in fact, they have fabulous levels of antibodies in them. So what he did is he looked at how much antibodies were in the product, and then he looked at how many antibodies were in the blood of patients after they'd had the product. And these were really high levels, equivalent to someone with a healthy immune system. And then very reassuringly, he looked at the antibodies compared to healthy donors, and again found that the amount of antibodies were really functional from these antibody products, which is fantastic. So to me, this is some evidence that finally antibodies from the donors are coming through. We've got to remember, so this produces some kind of antibody equity with the general population. But similar to the general population, most of your immunity will be coming, therefore, from earlier strains, from the original, China Wuhan strain. And so what we're finding is, whilst those antibodies aren't protecting so much against getting the infection, they are protecting against severe disease and hospitalization. But it does bring up the antibody deficiency cohort much more in line with risks with the general population. Now, there are also a number of studies open for immune deficiency patients, which may actually give us access to some of these monoclonal antibodies. And I just wanted to make you aware of these, and also what the research environment is. Now, there's an ongoing Evershed study led by Oxford called Rapid Protection. This includes a number of immune vulnerable groups, but not antibody deficiency or primary immune deficiency groups. But this hopefully will give us important information about how Evershed has worked this winter in real life, because we want to understand, and NICE needs to understand, how the laboratory data compares to real life data. We've also got the PROTECT-V study, which antibody deficiency patients on immunoglobulin can now be enrolled in. We've managed to get a change to the study protocol to enroll patients on immune deficiency in these. And this is with the monoclonal antibody called sotrovimab that we've been giving in hospital. Now, this is given at a much higher dose than we're giving in hospital. And it's now open in 11 sites that you can see. So it's worth checking with your doctors if this is something that you wanted to be part of. But it's a way of potentially being involved in some of these antibody deficiency trials. I mean, it's my opinion that these antibodies that are potentially going to be the way forward for many patients with antibody deficiency. Immunoglobulin is great, but we know that there are risks associated with that. And we know the amount of antibody in that is only as reliant as your donors. So if we have new infections, we know that because immunoglobulin takes about 18 months to get to market, that, you know, it'll take a long time for those to trickle through. So, for example, for new flu variants or something else, if we could have monoclonals used as pre-exposure prophylaxis or preventative treatment, that's got to be the way forward. And I think this is going to change the whole way we prevent infections in maybe 10 years' time for patients on with antibody deficiency. Now, I'm also pleased to say that we have just received a very large grant from the National Institute of Health Research, which is funded by the government, to continue to monitor patients who are immune vulnerable. And I've absolutely made sure that we've got an immune deficiency group in this. And actually, I'm leading this out of Birmingham. It's a study called Stravinsky. And we're not doing anything in this study apart from monitoring and seeing what is happening. And the reason for this is, remember I said there's a group of you that don't respond to vaccines. And there's a number of patients who we found who are more likely to be hospitalized. And we want to see whether the amount of antibodies individuals produced can predict, and can we find almost like a risk stratification to determine who is most vulnerable to infections going forward and could then be highlighted for early treatment and prioritized for early treatment. So as I say, we're not intervening in any way, but this will be a really important study that will inform the government what we should be doing with vaccines, with treatment interventions, and hopefully just allows us to make sure that the government has a window into you and what is happening over the next 2 years, so that you're certainly not forgotten. There is also a study that is open called Evershell that is, well, we're calling it Evershell 2. It's also called Supernova. And there is a new type of Evershell. So AstraZeneca have changed the antibody slightly to make it more responsive to some of the Omicrons. And the sites for this are just being opened at the moment. So look out for that as well. There'll be lots of advertising, I can imagine, around that over the next few years. Now, this is, at the moment, they've said for the immune vulnerable. I'm trying to get clarification on whether this will be extended to patients on immunoglobulin, like Protect V has done. And I will certainly lobby for that to be the case, because it's really important for me and you particularly to understand, is the antibodies you're getting in immunoglobulin enough and working in real life, or would you benefit from an additional top-up from one of these monoclonal antibodies? So that's what's happening. And I completely agree with many of you that COVID is not over for patients with immune deficiency. But things are much better, and we do need to continue to live with COVID. And there's certain things that we can do to minimize risk. I think that when we talk about risk, this isn't a binary thing. This isn't a you're vulnerable, you're not vulnerable, you're at risk, you're not at risk. There's a real sliding scale there. And there are a number of things that you can do to reduce your risk of infection. So, using masks if you're in crowded spaces, decide, say, not to go on commuter trains if you can, or, try and shop at times when things are more quiet. These are just small steps, which a lot of you do anyway, to reduce risks of infections. Obviously, trying to avoid people if they are unwell, to stop that spread. You know, speak to your workplace about your risk and reasonable adjustments. And I'm sure many of your clinicians will help you with letters around that. Do get all your vaccinations, because there's good evidence that we've got now. Those vaccinations are doing something. And I think that is a significant part around why outcomes are better now. And encourage your family members and those that are closest to you to get vaccinated. Most of transmission of COVID has happened, you know, in the family unit, where, you know, obviously you're spending time together, that risk of spreading is much, much higher. And we do have access at the moment to lateral flow, so please do test if you get it, and try and contact the COVID medicine delivery units or the CMDUs. Now, you can do this through calling 111, or from calling your GP, or from calling your specialist unit. Unfortunately, I, as a specialist, I can't prescribe these drugs, antivirals and monoclonals for you. If you get COVID, at the moment, they all still have to be given through the CMDUs. And I know through bitter experience, this often requires a bit of a battle to explain that you are immune vulnerable. And even though you've just not got many symptoms at the moment, it's, you know, it'll take you potentially longer to clear the virus, etc., etc. And so quite often we just have to have a little bit of battle, but just do keep going. And I think it is still worth having these early preventative treatments, certainly at the moment. So that's where I'll leave it. So thank you very, very much for listening. And I hope that helps a little bit. I certainly don't have all the answers, but I promise that I will be continuing to do what I can to support our community going forward. Thank you very much.
Thanks ever so much, Professor Richter. That was an excellent presentation. I'm sure everybody will agree, and it's generated lots of questions in the chat.
No problem.
So the first one from Karen: are you still researching the specific antibody deficiency study, and if so, do you need any volunteers?
Oh, thank you. Well, what we're doing is the population is, we're now moving all these immune vulnerable groups to this big study called Stravinsky that I mentioned. And so we will need some volunteers. It's going to take us about a month to get everything up and open. If you imagine, we've got to go through quite a lot of governance to make sure it's all ethically approved and the hospital sites are able to recruit patients. So I keep a Twitter feed going, which I can put in the chat, but I will certainly be advertising as soon as we are open to recruit patients for that. So thank you, Karen, for asking to volunteer.
Okay, thank you. Next question is from Errol, has two parts to it. Is there any news on possible treatments for people who do not generate a response to the current vaccines? And are the hospital trying to identify such patients?
So are there treatments? So the best treatments for patients who don't make a response are antivirals, but also we're now increasingly seeing that maybe the monoclonal sotrovimab may be having some impact. So that's where the CMDU will assess you and either give you the antiviral, usually Paxlovid, or the monoclonal sotrovimab. And hopefully that will mean that you won't come into hospital. But if you did get admitted, then there are other antivirals as well that they can give to help you with that infection, but also give you treatments to try and settle down any inflammation in your lungs. So it's likely you'd be given antibiotics and steroids to dampen down that immunodeficiency, that inflammation in the lungs. So we've got much more tools and many more treatments than we had right back at the beginning. So if you don't make any response, we've got much more experience now of trying to work out how to treat you and what to offer you. What was the second part?
It was, are the hospitals trying to identify such patients?
Not at the moment, because there isn't an agreed treatment pathway of what we should do. So this is part of what the Stravinsky study is going to do, is work out whether it is clinically useful to measure antibodies in immune vulnerable patients. So should it be part of a clinical pathway? So, you know, it's a bit like, I mean, the example I always give is you can measure a serum rhubarb, but what's the point in measuring serum rhubarb if you don't know what serum rhubarb means, or if you don't know what you can do with serum rhubarb? And, you know, the argument that we're getting at the moment is whether you produce antibodies, you don't produce antibodies, we don't really know what we can do to intervene or make a difference. So you'll find some centres will do it to find where you are, but it is certainly not in routine practice.
Okay, thank you. Here's an interesting one. This is from Stephen. Has any study been completed in relation to mental health of immunocompromised who have or continue to shield?
No, but not formally. There are some kind of general mental health studies that have been done. And I think we can extrapolate that, you know, certainly there's been a significant impact. And I think people have talked not just about the mental health burden, but, you know, economic burden as well, because some patients haven't gone back to work. It's had impact on things like schooling for you know, children of who are affected and of those that are affected. So yes, no formal studies just in the immune compromised, but there is significant data coming through on that. And I think that is some of where it's a little unusual for me to be sympathetic to the government, but actually they're between a rock and a hard place on this, because they recognize that there are harms associated with lockdowns. And undoubtedly we're in the middle of that, aren't we? But if you don't, so there's harms associated with locking down and shielding. So they're kind of saying, okay, well, let's not do that. Let's just tell everyone to get straight, you know, get back to work, crack on, get on with everything, because we know it causes harm. But then for the immune vulnerable, that means that they are at risk of infection. So it's a real rock and a hard place between this. And this is where I do try and give a good news spin on this, because things are so much better. And actually the risk of, you know, of a severe outcome now in the immune vulnerable is, you know, so much less than it was. And there are also other things that we know that you can do to prevent infections. And we know that as a community, the immune deficiency patients are really good at this, as you could see from some of my graphs showing the difference between the general population getting infections and the immune deficiency patients. So I hope that helps a little bit.
Okay, thank you. The next question is from Sarah Drew. So MQI, for those of us lucky enough to receive some COVID antibodies via immunoglobulin replacement, can testing tell us whether we have had a COVID infection, or would the antibody replacements skew the results, potentially creating false positives?
Okay, so there are two types of antibody tests that we do. There's the spike antibody and there's the nuclear capsid antibody. Now, when you have an infection, both the nucleocapsid antibody and the spike antibody will be positive. If you're vaccinated, you're only being vaccinated against the spike, because that's the bit that allows the virus to get into the cell. So what we can do is test for both antibodies. And if you're nucleocapsid antibody positive, we can tell that you've had the infection. Now, this isn't quite so useful for patients with antibody deficiency, because antibody deficiency patients often don't make their own antibodies. So if you don't have any nucleocapsid antibodies, it doesn't mean that you haven't had infection necessarily. It might just mean that you haven't made a response to that infection. So it can be quite difficult, Sarah, to work it out. But that would be the way that we do it for most people.
Thank you. Gary's asked the question, I think you touched on this actually in your presentation, but will immunoglobulins have high levels of COVID antibodies?
Yeah, and they do. But those antibodies are now they're old antibodies in that they're against the Wuhan strain. But that's where I think that, you know, there's this concept of antibody equity. Actually, the antibodies that most people have in the community are also against the original Wuhan strain. So it kind of, at least it levels up the playing field a little bit. And we know that those antibodies, although they're not protecting against getting infection from the Omicron viruses, they are having a massive impact on reducing hospitalization.
Yeah. How do patients know what response they have made to the vaccinations?
Now you're on immunoglobulin, and now you're on, if for patients on immunoglobulin, this is now impossible. We can't tell the difference between what's in the immunoglobulin and what's in the virus, unfortunately, and what's in what you've had from vaccination. So that's not possible. But if you're not on immunoglobulin, you can do antibody testing. But again, it depends, you know, there are lots of different antibody tests out there. So they really should be interpreted by someone who knows and can understand antibody testing.
Thank you. We've had a couple of comments on here about how long people had the virus for. It was really interested in your presentation. Our poor patient, a year, was it? Oh my goodness. Before they tested negative. That I can't imagine. Karen said she didn't clear the virus for 3 months.
All right.
Stephen said he had COVID. It took him about a month, and the second time just a couple of weeks. So it's quite variable, isn't it? So
it is. And something on that, what I've really noticed, now this is a bit anecdotal, so please don't take me as this is evidence, but for patients that are getting the virus this winter who haven't had any infections before, who even have a healthy immune system, are taking a number of weeks to clear the virus. And what I'm finding is the more infections people have had, the quicker they're clearing the virus. So, you know, the immune system's getting better and better at clearing this. For 3 weeks, say, after getting an infection, I would say that's almost pretty normal now, if that's your first infection. Obviously, what I'm doing with patients is saying, you know, I wouldn't bother testing for at least 3 weeks after the infection, but then to test maybe every couple of weeks on your lateral flow to see how you're going. But for patients that are getting persistent symptoms like fevers, like cough, and they're still testing positive, they could have persistent active virus that's causing inflammation. And I would really encourage patients like that to talk to. I got muted there.
Sorry, I got muted as well. Just lost your sound. Yes.
I don't know what you heard there, but just to reiterate, if you've got ongoing symptoms and you're still testing positive, please go back to your hospital team.
Thank you. We've still got a number of more questions, but I've had a message saying to wrap it up. So because I think we've got the next speaker waiting. But thank you so much, Professor Richter. That was an amazing presentation and question and answer session. So thank you.
Good luck, everyone.
Could I ask one question?
Yeah.
Can I ask the question? It's just that I had very bad response to the vaccine. I was very ill. I'm really scared to have the next one. I haven't had it, but I've also been in hospital twice with COVID. They did say it stayed in my body. I had it from November till the following June in the first wave. I've been well since, but with the Pfizer, I was terribly ill with nosebleeds and temperature and couldn't get out of bed for over a week and ill for nearly 3.
Pat, I hope you don't mind, but I think it's probably best that I don't give personal.
No, I understand. I tried to send it on the chat. I don't know whether it went through.
What,
I'm not very good with this
what
stuff.
I would, have you spoken to your clinical team about this?
I have, but they just really said we can't say that you shouldn't have it.
Okay, but just drop me an email afterwards and I'll deal with it personally rather than in a public forum. Is that okay?
Thank you very much. Thank you.
Okay, bye-bye.
Thanks very much, Professor. I really enjoyed that talk. Useful information, and thank you for making those technical slides so understandable. That's an art in itself. Okay, right. Well, thanks. If we have time in the next Q&A session, we may be able to pick up some of those questions. Just depends how that goes. Okay, so we'll move on now to the NHS update from our volunteer, Sue Dimmock. Over to you, Sue.
Thank you very much. So for those of you who don't know me, first of all, I should say to Alex, that was a absolutely fantastic presentation, and you've probably covered off quite a bit of mine, so mine hopefully won't take as long as I thought it would. So anyway, for those of you who don't know me, I'm Sue Dimmock. I've been with UKPIPS as a volunteer for about 6 years now. And I need to say that I am not medically trained anyway, so please no difficult questions for the doctors. What I do have is a really keen interest in my condition and how it impacts me. And that's why my role with UKPIPS tends to cover the sort of more medical matters. I maintain contact with the NHS services across the UK. I sit on different committees. I talk and I contact patient charities regularly. I talk to the pharmaceutical companies who are producing immunoglobulin regularly, and I maintain contact with our medical panel. Our medical panel, if you're not aware, they're a small team of volunteer specialist immunologists, and they provide UKPIPS with advice and support when we have some sort of difficult questions on medical matters. And I'm delighted to say that one of our medical advisors is here today. So my talk is going to be about 20 minutes long, and I was going to update you on a number of things, but I think I can probably avoid the COVID treatment bit completely, other than just maybe a quick comment. But so UK plasma, COVID treatments, changes in the NHS, and our Facebook community. And as others have said, I'd encourage you to put any questions that you've got into the chat. And if we don't get to cover them, I will get back to you using the email that you've come into the meeting with. So, okay, let's start with UK plasma. And I thought it would be useful because we had a big sort of song and dance about UK plasma and why wasn't it being used. And you know, the ban was in place implemented in 1998, and that was as a result of the outbreak of mad cow disease. And as a result of that, 100% of the immunoglobulin that we use as patients is currently imported from both the US and Europe. Now that may be fine, it may not be fine, but I think this all came to a head when we had shortages of immunoglobulin, and we've had a couple of significant shortages of immunoglobulin. And I think at that point, you know, a lot of people, including myself, started to ask questions about why are we not making use of the plasma that we've got available now? It hasn't been used in manufacturing, but it's been used for other applications across the NHS. So after a lot of campaigning over a number of years by both us and other charities bringing together a sort of a huge body of evidence, the ban was lifted in February 2021 when the Medicines and Healthcare Regulatory Authority actually approved UK plasma again for manufacturing purposes of immunoglobulin and other products. So at that stage, the NHS was then asked to appoint a fractionator for UK plasma. And that's when things began to slow down a little bit, because we hit lots of sort of regulatory issues around the rest of the world where UK plasma hadn't been approved, and it wasn't authorised for either import or manufacture. And so what the NHS through the Commercial Medicines Unit did during 2021 was to work on a lot of those regulatory issues, and they talked to a lot of the pharmaceutical companies about how they overcome. And eventually they did release in, I think it was the middle of 2021, a tender, or it may have been, apologies, my recognition of time frames is not great because 3 years have just gone into a blur. Anyway, so they released a tender for a fractionator. And we're now in the process where those tenders have been reviewed, and we're awaiting an announcement on a fractionator and a reserve fractionator. We hope that that's going to happen this month, but there have been a number of missed deadlines due to all of the, sort of issues that I've mentioned. So once the fractionator is appointed, we move into what's called the mobilisation phase, when the NHS will be talking to the appointed tenderer or the appointed fractionator and trying to actually get this into mobilisation, so into a production phase. So just to temper your expectations, we are not likely to see plasma products, UK plasma products, until mid-2024 at the earliest. But there are plans, and certainly NHS Blood and Transplant, who collect all the plasma, have plans for us to become about somewhere between 20 and 30% self-sufficient. I just mentioned NHSBT, but we need to have a huge shout out at this point to all of our members who have been really actively involved in the media campaign around increasing the plasma donor pool. And you can see some of them on the screen there. We've got Simone, we've got Jodie, we've got Linda, and we've got Leanne and her 2 children who are also immunodeficient. I should say, for anybody who's joining from anywhere other than England, and I know that there are people here, we are at the moment the only nation who is collecting plasma, but I do know that the devolved nations are developing their own collection plans, and so those services will come online in due course. And I've just put the details up on the screen there of how to contact NHSBT, but literally, I mean, it's just a search on the web if you want to find out about plasma donation. Okay, moving on. I was going to talk about COVID treatments, but and primarily all I need to really say here is, because Alex has talked in detail about this, is that, we are very grateful. We're very grateful for the fact that we've now got COVID vaccinations, that we've got COVID treatments, and that the SARS-2 COVID antibody levels in our immunoglobulin, is increasing. And Alex said that we need to find out when that reaches a point where it's going to be protected. That's a very difficult question, likely to be different for each of us. But this is obviously a really different picture to the one that we had 3 years ago, when I think we all doubted that we'd get through if we caught COVID. And unfortunately, I think we all know people in our community who sadly did pass away. And our thoughts are obviously with them and their families. But so very quickly, in terms of treatments, Alex has mentioned what you need to do if you get it. Perseverance is absolutely essential, and I can tell you that from my own experience. I tested positive on a Sunday, and I literally was tearing my hair out trying to get through to somebody who was going to listen to me. And the treatment list, as Alex also said, changes quite frequently. But at the moment, the commercial medicines delivery units are still responsible for deciding which drugs you have. But I would encourage you to also let your teams know, because they may have specific instructions for you, as Alex said. The thing that we also need to mention in terms of treatments is that sadly at the moment, children under 12 technically don't have access to COVID medications through the NHS. So we're just hoping that there might be some developments on that in 2023. And that's actually probably all I need to say on that slide. I will move on very quickly. I'm not going to say anything about COVID preventatives because Alex covered it really well in her talk. The only thing I am going to say is that I just hope to goodness that with the NICE appraisal being announced, I think it's going to be formally announced on the 16th of February. you know, we know that we've missed the boat on Evershed. That's been fairly apparent for some time. The Food and Drug Administration in America have put it on hold. So I think the issue for me is the fact that, you know, we lost a year. The FDA approved it in early 2022. If we could have had a much slicker process than the one that's been employed by DHSC, I think we would all have been in a much better position now. We may have had something that would have given us the ability to carry on and live our lives normally. And I think Alex mentioned Evershed 2 or Supernova. There are also sort of other possible treatments, I think, out there, but you know, there's not much information on those at the moment. Things like hyperimmune globulin, where we could collect and concentrate antibodies from plasma. But you know, the thing I do need to say is just that I don't want us to have to go through the same length of process that we've been through this time, because we'll never get a decision and we will just simply be, you know, chasing variants all the while. So it's really important that we do, you know, have the ability to have a slicker process. And I'm hoping that NICE will announce something around. Okay, don't want to say too much on changes in the NHS, but just to sort of let you all know that you may have seen quite a bit in the press around integrated care systems, integrated care boards. Essentially the clinical commissioning groups where funding for the majority of medication comes from are going to be subsumed into the integrated care boards. Now, up to this point and going forwards for about another 12 months, funding for immunoglobulin has always been managed at a national level. So we've had specialised commissioning, and that will still be there, but the funding for immunoglobulin is going to be divested to the integrated care boards. The NHS hopes at some point in 23, 24, I believe. Now, the question then is, what does that mean for us? And the answer is, I haven't got a clue. You know, I don't know what that means, but I think it's really important that I mention that that's going to be happening, because I do have concerns around the fact that that funding is going to be divested. But watch this space, because I think we're still, you know, we're still talking, we're still having conversations about that. My concerns are around standards of care and, you know, how care is going to be coordinated around the funding for immunoglobulin. So I think it's important to iterate that the NHS will retain the responsibility for the national standards that we have at the moment. That's the service specifications, and also for the accountability. So the most important thing for you to be aware of is the fact that you do have a voice as a patient, and that's both individually but also through you know, charities such as UKPIPS acting as your community voice. And I will continue, as long as I'm able to do my best to raise issues that we see, as long as you let us know about those issues. And if there are any variations in service levels developing, we'll be on those, you know, as quickly as we can be. And we've got the ability to sort of talk to different areas of the NHS, the CQC, and also quality in primary immunodeficiency services, QPIDS, about any issues that we see. So finally, and I promise you this is my last slide, and time-wise I'm not doing too bad. To end on a slightly more positive note and say, Facebook community group. I just wanted to say that we do have both a public and a closed Facebook group. I'm not sure that there's quite a few people here that I haven't really seen on the closed group. So I just wanted to talk a little bit about that and say, if you'd like some more information, just put your name in the chat and I can let you have information about that. But it's a really good community where families, patients, carers, you know, have the ability to ask those awkward questions that you wouldn't want to do on the public page, obviously. The other thing is that through that group, we also run a weekly Zoom chat for our community, and I can see quite a few, I have seen quite a few people here today who attend that chat. It's a really friendly session at 12 o'clock, and we just allow people to just come in and talk about anything and everything. So join us. You know, it's open. There's no commitment to stay. There's no commitment to get involved at all. You can just come and listen if you want. So let's say, pop your name in the chat if you're not aware of either of these two things, and I will get back to you with some information. So that's it from me. Thank you for listening, and I really hope that it's given you a bit of a flavour of some of the things that I do as a volunteer with UKPIPS, and also to give you a little bit of an understanding of what's going on behind the scenes, because we don't have the resources to let you know about all these things all the time. So yeah, just you know, and if you're interested in UKPIPS, the charity, and want to get involved with it, again, let us know, because we, you know, we're in a position where we would, we'd love to get, you know, more of you on board and help the charity.
Well, thanks very much, Sue. Slight change in the programme. We think probably now is a good time to have a comfort break. So what we're going to do now is have a 15-minute comfort break. So get a cup of coffee, cup of tea, whatever. And let's aim to be back at, say, 25 to 12, and then we'll follow through the rest of the programme. Okay, see you in 15 minutes. Right, okay, well, it's 11:35, so we'll make a start with the afternoon, well, the sort of post-comfort break session. And first of all, May, you're going to talk about PIP in Scotland.
Yes, hello, good morning, everybody. This is some words from Michael Howell, because he has unfortunately lost his voice, but so we're very grateful to Michael for putting this together. And I'm sorry, but I haven't got a presentation to put forward, but I'm sure if you want to, we can give you the paperwork that we have put together. Can I just ask, how many of you do come from Scotland, please? Could you just raise your hand? Right, okay, that's we're a very small group here, Michael, but I think a lot of the work that you've put together is exactly the same for England. There are just a few slight differences. So Michael is a volunteer with Carol Hazard in Scotland, and he represents the UKPIPS at NHS Scotland. So we're very grateful to him for the work he does. But he's put together this short information about adult disability allowance in Scotland. And like in England, you can either apply online or via a paper application form. And the application form asks about the following: how easy or difficult is it for you in either preparing food, eating and drinking, washing and bathing, your toilet needs, dressing and undressing, communication, reading and mental health, and your physical mobility. So when you're filling in these forms, it's important that you think about how you are when you are ill or in your worst phases, and what effect that has on your ability to manage these areas. Because as you know, your ability to do things will change with how you are feeling and how ill you are. So just think about what your needs are when you are really in a bad way. Once you fill in the form, it can take up to 8 weeks for a decision to come through. And the Benefit Office in Scotland will ask your GP for the details of your health condition and may phone you or arrange to come to your home to discuss your health if they need to. So how much do you get? Well, the following payments are fortnightly and are per person, regardless of your marital status. There are 2 components, as there are in England and Wales. There's the components for daily living and the one for mobility. On the daily living component, you can get if your ability to carry out day-to-day activities is limited by a physical or mental health condition or disability. and the minimum rate is £61.25 and the maximum is £92.40. With a mobility component, you can get this if your ability to plan and follow journeys or move around is limited by a physical or mental health condition or disability. And for that component, the minimum rate is £24.45 and the maximum rate is £64.50. The range depends, in the rates depends on your disability and your ability to do the things that they are looking at. So if you are successful and get a PIP, you do not have to apply for Scottish benefits. Now, I don't know how that is different in England, but probably Sue can put that up on the chat. So what the information and more help you can find by looking at Citizens Advice Scotland website under their benefits section. And you apply online either via mygov.scot, or you can phone Social Scotland free on 0800 182 2222. Thank you, Michael, for putting that together. I'm sure that's helpful for people, and we can send it out to those who, if you want to put it in the chat, we'll send it to you. So thank you very much, Michael. That's the end of our presentation, Paul.
Now we'll move on to Errol, who's going to talk to us about the survey we did last year and our fundraising opportunities. Errol?
Good morning, everyone. I'm Errol. I'm one of the volunteers of UKPIPS. Just a little bit of background. I live in London. I was diagnosed with CVID back in 2013. So I'm under the care of the Royal Brompton. And primarily why I try to get involved in charities to try and support people like myself by understanding, what we have to go through. By understanding people's situations in most of the cases, because obviously every case is kind of different, every person is different. So that was kind of that is as to why I chose to put myself forward and support the kind of the charity. When myself and Paul joined back in at the beginning of last year, as volunteers and trustees, what we try to understand is, where the charity was at that point in time. What is it that our community is looking from the charity? What is it we can do to better support our people? And how things are going in general. So as Paul mentioned, we sent out a survey back in July, I believe, if I'm not mistaken. Time flies, and we got quite a few responses, which was really, really positive. So I'll share my screen and I'll give you some of the highlights and a little bit more information about what we do and how we operate. So this was the rationale behind the survey, basically. So as I explained, so we tried to understand where we are as a charity. We wanted to recognise what's important to our community, evaluate some of the options and look at the feasibility of those options and those proposals that came from our community, and hopefully try and deliver on any kind of viable projects. As I explained, this was completely designed and managed by the trustees and the volunteers. We had 66 responses. Out of those, 60 identified themselves as being patients. 2 were carers, our carers, and 4 our family members. As I said, we got some really, really useful feedback and suggestions, and we'll try and take some of those kind of going forward. In regards to the interaction with UKPIPS, as you can see, Facebook appears to be the kind of the favorite mode of contact for our community, followed very closely by the website. But of course, the Friday Zoom that Sue mentioned and has been going on for a while now, and it's of great support to our community. That's one mode of contact as well with the charity and interaction. As you'd expect, because of what's been happening in the past, we did a little bit of an exercise of gathering as much information as we can as to the type of information that our community is looking for. And again, as you'd expect, information was the kind of the most used word, followed very closely by new treatments, advice, knowledge, and so on. So there is a demand there for more information in general regarding the charity itself and regarding, you know, what is happening in the PID space. We also asked the question as to, you know, this is what we provide at this stage, or these are some of the support functions that we've got in place as a charity. Going forward, what sort of support and what sort of advice, you know, what sort of support would you like to see from our charity? And as you can see, again, the most kind of used word was advocacy, advice, benefits advice. So those were like the most used words based as to the type of support that people would like from us. So we've evaluated the kind of feedback that was given to us, and we're really grateful for from our community. And as in response, we started a newsletter, which hopefully you should have all received and read, and we'll continue to do that. Obviously, we'll continue to keep you all up to date via our existing channels, so the website or email, our Facebook group, and our Friday Zoom. We have continued communications with pharmaceuticals, and we have regular meetings with our very, very valued medical panel, as Sue mentioned before. And we are in the process of contacting, we've contacted a few people prior to the new year, possible trustees and volunteers. And the last kind of point is really, really important to us.
I know why.
What I wanted to kind of highlight is that the charity itself is run by volunteers, and any support is obviously appreciated. So we are a very, very small team, and you know, we give up our time because our ambition, or you know, what we want to do is support the community and support the charity as best as we can. We always try our best, and I hope that, you know, people appreciate and understand that. If you'd like to get in touch with us, you can send us a message via the website on the contact us section. You can reach out to us via the Facebook group, UKPIPS group, or you can also email us at info@ukpips.org.uk. As I mentioned before, so not only are we run by volunteers, but we also rely on donations and sometimes grants to fund and to fund projects and initiatives, basically. So when we are looking to deliver an initiative or a project, we have to make every single penny count. We haven't got unlimited amount of funds, and therefore any donation, large or small, is always welcome. And if you're unable to donate, I think if you can donate your time, that's also appreciated as well, or that is appreciated as well, not also. If you'd like to make a donation, underneath there, you've got the donate function in the UKPIPS website. This is what the page looks like. So in the red section where it says please click here, that's when you can make a donation. However, you can also contribute in other ways by clicking on the function underneath. Lastly, as I said, we welcome any sort of support that you can give to us. We welcome any ideas, any initiatives, any feedback. But without any feedback, without anything, you know, we're sort of stuck sometimes as to, you know, what do we do kind of going forward. So any feedback is welcomed. And that's pretty much it for me. I'm not sure if you're taking questions now or later, but if you've got any questions, please feel free to put them in the chat. And thank you very much.
Thank you, Errol. Has anybody got, if anyone's got any questions, if you could put them into the chat, that would be great. Shall I see if we're able to answer some of the questions that we didn't get a chance to earlier? Yeah, there's only a couple actually, and there might be specifically for Professor Richter to answer. So is she still on the line? I'm not sure if she is. So I'll ask the questions anyway, and if there's anybody on the line that is able to answer them, then please feel free to do so. If not, we'll pose the questions to the Professor offline and let the individuals know what the responses were. So let me just go back to them. Just 1 second. So one of the ones that was mentioned wasn't really a question but a comment. So somebody was mentioning that they're in a Facebook group to try and get the Epishield available. So so watch this space, I guess, with that. I don't know if that person would like to say anything about that.
Is Alex here?
No.
No. Okay, I can answer that one. I'm assuming that we're talking about Evershield for the UK,
Yeah.
and I'm also a member, and I think probably a large number.
Sorry, yeah, that was me. So there is a
the issue
it's
with
in the sort of in the Facebook group, and they're quite active in trying to.
Your connection's really poor, Karen. Sorry.
It sounds interesting that there's to be a new public consultation. I know.
Yeah.
Sorry.
Yeah, no. What I was going to say was we know, and we're in touch with Evershield for the UK. I've had a lot, and I know Nicola very well now. So we've been in touch quite regularly. We are also involved in the NICE consultation process. I'm going to a meeting on Wednesday before the public announcement on Thursday around Evershield, but as Alex said in her talk, you know, essentially we have missed the boat on Evershield as a treatment. What we're looking to now is Evershield 2, or Supernova as it's being called, and there will be other treatments coming online in due course. So the issue was that in the UK, Evershield was approved in February 2022, but no decision on funding was made. And what happened was the DHSC finally decided they couldn't make a decision, so they pushed it out to NICE for a single technology appraisal process, which is just looking at cost effectiveness and clinical effectiveness. And the problem was we had a large turnover of health secretaries at the time, so it all got a bit sort of confusing and messy. So we didn't get a decision on Evershield as a treatment. So 12 months have gone by since then, and the effectiveness of Evershield itself is probably much reduced now because it's not covering all of the variants that we would want it to cover. So we're looking at, you know, and I'm not an expert. Chris may want to say something here because Chris is much more of an expert than I am on this. He's probably much more up to date than I am on this. But it's, you know, we're not in a position where I think Evershield will be funded, but hopefully the process for Evershield 2 or Supernova can be speeded up and we can get access much quicker next time. Chris, did you want to say anything? Not a problem if you don't.
Okay, thank you, Sue. Another question that didn't get answered, and it probably is a question for the professor as well, but is CMDU being reviewed? Having a parallel system independent of your consultant seems incongruous to me, not the normal model for managing immunodeficient patients. When will we get back to a more normal BAU model where your clinician can decide the treatment course for COVID? Is there anybody that can answer that question, or should we pose that one to the professor?
Do you know what I actually found? Sorry, Stephen John here. I actually found when I actually had COVID on both occasions, it was by the time I'd actually spoken to the medical team, it would have been arranged for me to go to the CMDU. which is what they would advise, and I'd had the same treatment both times. So it's not that it wouldn't have worked as quickly with going through the medical team, but it worked at a, it wasn't a slow process, put it that way, to decide of whether or not any of the treatments would have been possible or necessary.
Yeah, I think it's, from my perspective, you have to report your results online, and I think we all know that, but you report your results online if you can. If you can't, then you report through 111. If you're not getting a response that you're expecting, please go back and contact 119, because they should be able to, you know, to help. So it's a case, from my perspective, when you get COVID, if you're unfortunate enough to get it, you've just got to persevere, you've got to keep going. The CMDU should contact you, but unfortunately, particularly at weekends, I know in my particular geographical area, they don't work at weekends. So you're scuppered. You have to wait until Monday until they start picking cases up, and then they'll prioritise them in order. So that's an issue. In terms of Chris's question, is CMDU being reviewed? I'm not 100% certain. I've seen a couple of suggestions that it is, but I agree with you, Chris, that we need to get back to business as usual, and consultants should be able to prescribe the treatments that we need. I think one of the biggest issues with that, and whether or not somebody sitting at CMDU is the best person to make a decision about all the other treatments that we're on, but we do need, I say this is where the complexity of our conditions comes in, because we have, a large number of us will have comorbidities, be on a number of different medications. So it needs somebody to review that across the picture in order to make a decision. Are our immunology consultants, able to do that in all cases? I don't know the answer to that. Maybe Patrick or somebody else might. Patrick might want to answer that one.
Yeah, sorry, I don't actually have a camera on this PC, hence you can't see me. But I think, like everything in the NHS, things are reviewed on a regular basis. I'm not aware of any specific thing to review the CMDUs at the moment. But Sue was alluding to the other complexity with the CMDUs. They don't just give out COVID treatments for people with immune deficiencies. They've got to deal with a whole bunch of loads of other things, transplant patients, renal patients, et cetera, et cetera, et cetera. So it's a pretty broad church. And whoever the CMDU team is, they are responsible for essentially kind of looking at this entire sort of group of patients. In some, I think maybe 2 or 3 centers, it's immunology that's running the CMDUs. Some places have went for primary care doctors. A lot of locations have just really gone with what resource is best available. It'd be nice if each individual specialty got to look after its own set of patients, but I think the difficulty that is then the logistics of who runs the sort of administration centers, who deals with sort of sending out the tablets, so on and so forth. And also, not quite sure that every single department is well-resourced enough to actually run a 24/7, much less a 5-day service, 9 to 5, just being there to, if you like, sort of take calls and take emails or take kind of referrals in to treat people. So it's very regional, it's very varied. Everybody was kind of given instructions. This is what you need to set up. You need to have a service where if a patient meets X, Y, Z criteria, they get sort of given the drugs. But individual regions' resources obviously vary very greatly. And much to hate to, it's probably going to get worse because of all the, I guess, strikes and other things you read about in the news about the NHS. In theory, the system works. It really is very nice because, you record your COVID result on some national thing that automatically goes to CMDU and you get a call within the next working hours, whatever that is. Some areas, clearly the setup doesn't work quite so well and there is variability. I think, and I'm not sure there's any easy way to fix that because it's probably part of the inherent variability that's the whole national health, as it were. I think the same would be true if individual immunology teams were to take over. Some teams are better resourced than others. Some areas are really struggling with consultants. So I'm not even sure that that's the best idea, as it were. But yeah, we just generally need more staffing. But the system, when it works, does actually work very well. And to be fair, I think at least for the patients in my area, it seems to work the majority of the time rather than the minority.
Thank you, Patrick.
I suppose the one thing that is useful, and I'm again not very sure whether Alex Richter has known more about this, but it's to make sure you are on that list that auto triggers to the CMDU when you put up a COVID result. Not everybody seems to be, and it's very unclear who actually maintains that list. Central IT isn't wonderful. Your GPs ought to know this, but the IT system is big and labyrinthine and very hard to kind of figure out even when you're actually working in the system.
That's a really valid point. Thanks very much, Patrick. I think that's the labyrinthine nature of the NHS IT is well known. So yeah, thank you.
Brilliant, thank you. Another question that came up earlier. So this might lead to speculation actually, but will the vaccine become a bi-yearly or yearly vaccine moving forward, do we think? I think this is
do you want me to speculate on that?
It's up to you. I think it's something that can't be answered, isn't it?
No, I mean, it's pure speculation and will depend on things beyond medical factors, including A, how much money the government has got, and B, which parties in political power, as it were. The decisions aren't purely ever made on medical decisions. It's a combination of kind of what's acceptable to general public plus how much money there is in the coffers to actually pay for them. So I don't know. It'll be pure speculation.
Okay, thank you, Patrick. There's a couple of comments in the chat earlier about a couple of people aren't in the Facebook closed group yet, so if we're able to share how they can access that, and specifically the Friday Zoom too. So if you're able to put a link into the chat for people, that would be great.
Can't do that because it depends whether or not they're actually in the closed group. So it's quite it's complex in terms of getting people into the closed group first, and then I will contact people by email. So using the email that they've come into the meeting.
Thank you. Have you made a note of the people who have asked that question? That's great. So
I've got Karen and Gary at the moment. I haven't seen anybody else, but if there is anybody else, just remind me.
Okay. There's a question which a couple of people have answered in the chat, so it might be something that might be worth discussing so everyone else can hear. Jonathan had asked, do we hold charity fundraising events? So Errol and Margaret, I don't know if you both answered these questions in the chat, so I don't know if you want to share your responses to the team.
I just said, and I think I replied to everybody, that we haven't done any fundraising events for a little while because of the interruption of COVID, but we have been grateful for people who have organised their own events. So if anybody has any ideas on what they would like to do, please get in touch with us, and we can support you in that and provide you with leaflets and also publicity materials. So yes, please do. Yeah, sorry, that's the best I can answer that, I think.
Yeah, I think people do things individually, aren't they? I mean, I know I've done a couple of things. My work is very good at matching charitable donations. So if people work in a company that does something like that, that's always worth doing. But yeah, so get the juices going in your minds and think about some ideas, and to share would be fantastic. Something else that's been asked, which would be useful, I think someone actually putting it in. Somebody has asked for some, let me just find it, some useful numbers. Sorry about this. I've missed it. Somebody asked about some contact numbers for reporting, because it's confusing as to where to go, and I've just lost it in the.
Yeah, it's from Sarah Drew. Could UKPIPS provide a cascade of necessary numbers to call if one gets a COVID infection?
Just found that.
I'm not the best person to answer that question. Sue, have you any idea whether that is possible?
I'm sure if you Google CMDUs, you'll find a list of telephone numbers on the internet, but you don't really want to be ringing the CMDU because it's unlikely anybody will answer. I'm sure they'll be far too busy to take calls from individuals. If that's what you mean, Sarah, apologies if it's not. But the best thing to do is it's 111 and 119. So essentially 119 can provide you with the tests, but 111 is where you need to chase up if you've given a positive test and had no response. And in my case, as I said, I reported my result on early Sunday morning, and I was told I'd be contacted in 24 hours. I hadn't been, so I, by that stage, had contacted 2 of my teams, my specialist teams at the hospital. I'd contacted my GP, just to let everybody know what was going on and saying, can they please refer me in? And in fact, I think I ended up with about 4 different referrals into the CMDU. And I finally got a call on the Tuesday lunchtime. But that was because I contacted my team. Now, obviously, teams may not be able to deal with these issues all the while, because I know teams are very stretched, but from my perspective, it was just belt and braces. I was just trying to make sure that I, that somebody knew that I'd got COVID.
Because also, Sue, I think it's for some treatments, it's kind of possible that you should really have those treatments within 3 days of getting COVID. And if you're saying there's no weekend cover, well, that's 2 days straight away, isn't it?
They have changed it now. They have changed the deadlines. They're saying 7 days.
7 days, is it? Okay.
For the majority of treatments, but there's one treatment, I can't remember which one it is, it may be sotrovimab, that needs to be done within 5. So they've extended the timelines, but Patrick may want to say something on.
I was going to say, I mean, the safest thing to do, or actually the most whatever thing to do probably is to maybe contact your local team before you get COVID to find out what the local arrangements are. There is a lot of local/regional variation. I mean, I think it would make sense to tell your local team as well, because they may also be able to contact the CMDU directly if they're not the people running it. But you might want to do it in advance of actually getting a COVID infection. There is no, I think, blanket thing for the entire country, and almost certainly can be different in Scotland, Wales, and Northern Ireland as well, because I don't even know how it operates over there.
I'm under Royal Free. I was told to contact them, which is what I would do. I haven't had it yet, luckily. And I think there was about a 5 or 6 day window.
Okay, thank you. Is anybody else? Oh, sorry. Go on, Abigail.
The Royal Free told me, which is something that's really interesting, that if I get any symptoms whatsoever, whether it's COVID or not, that I should contact them and they would deal with it.
Yeah.
Have you had any similar, anyone had any similar advice?
Yeah.
Your immuno team can refer you in.
Yeah, I was told, so just per se COVID, I was told if I got anything to get in touch with them straight away, and they would contact, was it that CD? Yeah, anyway, they would contact them. And that's what I do. If I get any infections now, I just contact them. I'm on immunoglobulin, and I've got rescue antibiotic if I have to and I need them. I contact them first, I get permission, and then I take them.
Okay, thanks. Sorry to.
I was offered immediately. So as soon as I tested positive for COVID, I registered it in the same way as everybody else through the app, and I got texts within a couple of hours to say that I was eligible for the monoclonal antibodies, which I had. Has anybody else got any questions? There's nothing else in the group that I've noticed, in the chat that I've noticed. So if there's no more questions, I will pass back to Paul. Okay, thank you, everybody.
Okay, well, thanks very much, Emma. We're actually ahead of time, which is good. Can I just give everyone a last opportunity to ask any question they'd like to, or tell us what they'd want out of UKPIPS, or we all finish, want to get to our lunch? Okay. Meg, do you want to conclude the event?
I will do, yes. I'm with Paul. I'm a trustee at the moment. So it's my pleasure to say I hope you've enjoyed this morning's community event. It's the first one we've held for a number of years, and we would really be interested in your feedback, and also to know what you would like to hear about in any future session. So thank you very much for coming. As you will have heard, we are all volunteers who carry out work on behalf of the UKPIPS community. Carolyn, who you've probably seen, is our admin assistant and is the only employee, and she works part-time. So we are all covering at various times. So we're looking for people to help us in this work. So if you have time or skills that you are willing to volunteer, please let us know. You will probably have seen our adverts for more trustees, and this is really urgent. We must appoint at least 2 trustees and preferably 3 or 4 to ensure the future of the charity. So if you think you can help in any way or want to know more, please get in touch. You can email admin or info@ukpips.org.uk or go onto the website and just go through there. The charity doesn't ask you for a membership fee because we realise that most people, if you are with a primary immune deficiency of one sort or another, you probably have a difficulty in your finances. And so it relies on donations in various forms, and Errol has told you how to do that. And we're also grateful to Takeda for their sponsorship and to all those who have left legacies in their wills to UKPIPS. I think that's probably as much as I want to say about that. But so having given you a plug for more help and finance, all that remains for me to do is to thank everyone who has taken part in this session and enabled it to happen. We're very grateful for the interesting and informative speakers. That was Professor Richter, Sue Dimmock and Errol, and also to Michael for his input. And to Paul and his team who have organised this event, and to Nigel Good for hosting it. But most of all, thank you to all of you for coming and making this a successful occasion. We hope to see you again. So bye for now. Bye-bye.